This is the Water Your Garden podcast. I'm Sarah Michaels. This episode is all about you, your chance to water your own garden, pour into your own life, and grow. Welcome to the show. I am so glad you're here today. This is an episode I am deeply proud of because there's just so much value in listening to this episode with Dr. Thakore. Dr. Suruchi Thakore is a physician with Pinnacle Fertility who specializes in reproductive endocrinology and infertility. She is just incredible, you guys. Located in Grand Rapids, she came to Detroit to record with us, and we are so grateful because she is a wealth of knowledge. In today's episode, Dr. Thakore and I are talking about the main reason she sees women struggling to conceive, the facts around how difficult it really is to get pregnant, and why, if it's true that more women than ever are struggling to get pregnant, foods that boost fertility, and ways that science can help to get you pregnant. We also talk about the signs and the symptoms of PCOS, how to be an advocate for your own health, and Dr. Thakore shares stories of inspiration for those who are currently trying to conceive. We talk about how you can follow Dr. Thakore at the very end of this episode. You can find all of that information on my Instagram. If you know anyone who is currently trying to conceive, struggling with their hormones, or anyone who is interested in learning more about their body, this episode is a wonderful one to share with them. I know that they will thank you. Dr. Thakore is sharing outstanding facts for all women regarding their health. Dr. Suruchi Thakore, welcome to Water Your Garden.
Thank you. I'm so excited to be here.
I am so excited you're here. You drove in from Grand Rapids.
Yes, I did.
Okay, how was the drive?
Drive was great. There was very little construction, and I think we were able to make it here smoothly without any problems, so that's a good thing.
We love to hear it. I used to do that drive. I lived in Grand Rapids, and my husband was in Detroit, and we were long distance. I used to do it all the time. So we appreciate you coming in. I want to get started at the very beginning. How did you get started with fertility management and treatment?
So I think, it's a long journey, right? And so you have to do med school and residency. In order to do fertility, you got to do OBGYN. That's the way you get there. So we did my OBGYN residency. I absolutely loved it, but I love hormones. I think hormones are phenomenal. And the ability to manipulate hormones to get them to do what you want them to do is just like this next level, like fun, right? And so the place where you manipulate female hormones is the fertility world. And in the GYN, like what we call reproductive endocrinology and infertility. And that's all we do is we take the hormones that are in the body and fix them to work properly or manipulate them to do what we want them to do so we can get a good endpoint.
Saying that you love hormones is a wild thing to say to me in particular. And I know a lot of our listeners are going to agree with this. Ever since I hit puberty, hormones have been a problem for me.
Oh, yeah. I don't like experiencing hormones, but
they've been messing with me.
Yeah. But I like the fact that you can fix them. And that's the best part about this field.
Yeah. I mean, completely off script. Ever since I started having periods, mine were exceptionally heavy. Yeah. I would get really sick. I remember once I started hitting high school, I would get sick to the point where my stomach hurt so bad I was puking. And that is when birth control was introduced to me, simply because they said my hormones were, I don't know the right way to say it, but they said that essentially things were more difficult for me that time of month than other women. And I know a lot of friends who said it was similar and they were told to get on birth control. What are your thoughts on that?
Oh, that is so true. And so this is the thing is we call that medicine birth control because that's how it's marketed, right? But all it is a combination of hormones in one pill. And the purpose of those hormones are to help regulate the normal menstrual cycle so that way you don't experience all the weird things that happen that are maybe not as normal, in air quotes. And so calling it birth control gives it that false sense of, oh, it's to prevent me from getting pregnant. But its function is to help manipulate the system so then that way you don't experience all the extremes that potentially come with the hormones that then lead to the pain, lead to the heavy bleeding, the irregular periods, the acne, the thick
acne
hair
was a
growth,
big one. Yeah.
Right? All of those are hormone based. And you can use a pill that contains hormones to stabilize those hormones to make some of those symptoms go away. We just happen to market it initially as birth control, so we call it birth control.
That is so interesting. I've never heard it explained that way.
Yeah.
What is your take then on women being put on birth control so early in their life?
So we actually have lots of studies that don't show any harm for being on it.
Okay.
There's a lot of ties, and there are always going to be a subset of patients that are more sensitive to certain medications than others. And all of these pills contain estrogen, a synthetic progestin, so which is progesterone, and then they contain additives, to make the pill the color it is, or the shape that it is, or the, have the right absorption and stuff like that. And it's all those little additives that make people feel sick on certain brands versus others, or have certain side effects versus others, right? There are side effects for the estrogen and progestin that's in it, but for the most part, there's a lot of the people that can't tolerate it. It's because of the other additives that are in the pill. So therefore, if you wanted to solve some of these problems that women have and young girls have in early life, while their hormones are starting to establish and neutralize and their body's trying to figure this stuff out, you can use these hormones to help stabilize it until they're ready to get off of them. And then their body is in a more mature state, and now can actually do it on its own.
Fascinating.
Yeah.
It's nice to actually talk about this because there's so much chatter on social media right now around these topics. Do you find that you have more women coming into your practice who don't want to be on birth control at all, even if it's something that's suggested for them at their current time of life?
100%. And it's really because of the stigma of that it is birth control, right? I think one of the biggest disservices we do sometimes as physicians, because we're in so limited amount of time to be able to do it, it's hard to spend time to explain to a patient what you're actually giving them and why you're giving it to them and what is it going to do to their body to help them, right? And so I think what we run into is that people come into it being like, oh, it's birth control, it's got all these bad things, I don't want it. And I'm frustrated with my physician, so I'm coming to you for a second opinion because they're telling me I have to get on birth control. And then I sit down and I explain it to them, and I tell them what kind of options they have, and then they're like, oh, well, why didn't they just say that? I'll do it. And then they get on the birth control, And so, but it's not even just that. There's also, I feel like there's a generational concern with it too.
I agree.
And so I am a very outspoken woman in my Indian family, and I have lots and lots of young cousins that are much younger than me, and they would come to me with really horrible periods, irregular periods, missing periods, right? And I would tell them, they would come and say, hey, what am I supposed to do? How do I fix this? I feel horrible. And I will tell them the answer is birth control, and they'll be like, but my mom said I can't take that. And you're like, but did they explain to you why that you can't take it? Was there a medical reason you can't? Or was it just because they said, oh, you're not supposed to be on birth control because you're not supposed to be having sex, so therefore you don't need it?
Right.
And it's like, that's not the answer. That's not why we're explaining it and giving it to you, So I really think that when it comes to women coming to me and saying, this is what I was told I want, or I was to take, but I don't want it, if you can explain it to them why, I think they actually then have a better understanding of its function and why it will help them.
This is so great to hear from you as well because you work directly with fertility. So today we're going to talk about fertility on all ends of the spectrum, PCOS, being proactive, infertility management, and third-party reproduction. But let's start at the root, fertility in general. It seems to me, especially my age group, like 20s to 40s, I'm seeing more and more women posting online about difficulty getting pregnant and being fertile. Is it true that right now we're seeing more difficulty conceiving, or do you think that social media is just amplifying these stories in a way that we haven't heard in the past?
If you look at the statistics, and this has been studied for a while now, the actual rate of infertility is we used to quote it, 5 years ago at 1 in 8. So 1 in every 8 people are experiencing some version of fertility issues, whether it being getting pregnant or maintaining a pregnancy. So that includes the recurrent pregnancy loss. Okay. Now the newer data is 1 in 6. Okay. So it is, it's changing, but I also think it's no longer taboo. People are actually talking about it. I went through my whole life as, an OBGYN, and nobody came out of the woodwork at all. And then they heard that I started doing fertility. I trained in fertility, and now I'm a fertility doctor. And literally every other person I talked to, oh, when I was 20, I had trouble, or, oh, I have an IVF baby. And it's like all of these people that you knew from before didn't want to tell you their story until they knew you were in the field and then could understand it, right? I feel like now in the generation that we're in, and with the help of social media, it's becoming more normalized to, I have trouble, let me get help. Don't wait 5 or 6 years before you go looking for help. And I think that that's the story out there. So I don't know if that stat is true, an increase in infertility, or if it's more of just an awareness of it, so people are getting diagnosed more because of it.
It's so hard to say, because one thing I do love about social media is it really has made people open up and talk about things that you didn't hear about in the past. Yeah. And especially when it comes to women's health. I think there's so many topics that we weren't open about. And now you see, like, women such as myself, I'm posting online about things that I never thought I would be open about. I mean, what are the main reasons that you see women are having trouble conceiving?
Yes. And so, I think one of the big things we talk about is that not only are people having trouble getting pregnant and not like maybe talking about it, but now starting to talk about it, but we're also delaying our fertility, right? And so now, it's more common for a female to go into a more advanced education and take more time and spend more time in school, right? Get a higher degree, get a career, want a promotion. There's, for physicians, not, waiting to build your family until after you finished your residency, then your fellowship, now you're in attending, and it's like, okay, now I can start having a family, right?
Yeah, so you're 35.
Exactly.
Yeah.
And now you're 35, and you're like, oh, maybe I shouldn't have done that,
It's so hard.
Yes.
It's difficult.
Exactly. And so there's so many different social things, right? There's a lot of people being more financially responsible as well, right? People are like, I need to get married. We have to feel settled. We want to buy a house first, and then we're going to start having kids, right? Whereas before it was like, oh, we got kids and now we're getting married, or we got married and then the next year we have like a kid, right? And so that whole mentality of wanting to be financially stable also puts a delay on things. When it comes to the medical reasons for infertility, right, you're looking at, it's actually pretty split across the board. Male factor, meaning sperm issues of some sort. Female factor, typically ovulatory is the biggest thing. And so that means just not ovulating regularly, a hormone problem usually.
Is that LH levels?
LH levels. So LH is the hormone that helps you ovulate. It's the signal from the brain to the ovary to say, hey, kick that egg out. Okay. But there's so many other hormones as well. You've got your FSH, which is your follicle stimulating hormone, which makes the egg grow in the first place. And then you have to have that response from the estrogen and then eventually the progesterone as well, which then tells the brain, hey, I'm doing what you're supposed to be doing. I'm working for you. And then the uterus gets the signal that, hey, save this lining, a pregnancy may be coming down the road. And then if a pregnancy doesn't happen, the progesterone disappears and now you have a period. So that is your normal menstrual cycle. And it depends on all of these hormones to be able to regulate normally, or what we, in air quotes, consider normal.
When you go to the OBGYN and you're working to conceive, I have a lot of friends. Some of them it happened really quickly, and some of them it took quite a while. It's pretty standard to be told to try for a year, correct? Yes. And then if it doesn't happen for a year, then to look into your fertility. My thing is, as a woman in their 30s, I've never really understood that logic, especially as a type A person. I'm like, why would I try for a year not knowing if I'm okay? Because if you're not, then you wasted that year. I mean, what's your mindset on that? In my opinion, I'm like, why don't we all just figure out in our 20s how things are for us so we can be more aware before we even start trying?
Yeah, and that truly comes down to the old definition of infertility, which was age and time-based. Okay. The newer definition that was released in 2023 now includes a lot more, and it's more robust. Okay. And so this now not just includes 12 months of attempting pregnancy if you're less than 35, or if you're over 35, that timeline is actually 6 months. Okay. And then you're considered infertile. But it also includes now your medical status. So do you have a medical reason to need fertility help sooner? Do you have a partner status? So it now includes our LGBTQ plus population. single female, single male, all of those are now included in that definition of infertility. So it's now more broad, which then allows you to then bypass that timeline requirement as like before.
Right.
Okay. But the reason that timeline was initially established was because of just how long it takes people naturally to get pregnant. The ability for a young heterosexual couple to achieve pregnancy every month if they're actively trying is only 20 to 25%.
Really?
So only 1 in 4 or 1 in 5 people that are actively trying to get pregnant will get pregnant that month.
Wait, that's crazy.
No, humans are really not great at reproducing. Even
That's
though,
so wild.
again, going back to birth control, everyone, we pounded into people's minds that you're going to get pregnant when you're not trying, right?
Yes, exactly.
Yes. No,
Yeah.
actually, it's hard to get pregnant. It's not easy to get pregnant.
Wow.
So that's the reason why we had that timeline, because after 6 to 8 months, now a majority of people will get pregnant. But if you look at the standard deviation, your normal bell curve, right?
Mm-hmm.
Like 9 to 12 months is still reasonable before being able to get pregnant.
And does that statistic apply to, if you are trying at your ovulation peak, if you're doing everything right, you still have a 25% chance?
Yes.
That's wild.
Yes. If you think about it, I like to, the patients always ask me, they're like, why is that the case? I was like, you got to put it into perspective. The brain has to talk to the ovary and tell it to produce an egg. Then that egg has to actually grow. Then it has to ovulate. So then you have to get the signaling right to then make it actually release. Then it has to find the fallopian tube, which is its highway to the sperm. Then the sperm somehow has to get through the vagina, into the cervix, through the uterus, to the tube to find it. And they have to go the right direction because they technically have 2 choices. And the egg is only coming from one.
Yeah.
Right? And then the egg has to then actually be able to be fertilized. And then it has to grow and transport itself down the tube into the uterus. And then it has to find its friendly spot inside the uterus to implant. And that's just to get an implantation.
Oh my
Then
goodness.
it has to continue to grow after that.
Yeah.
And then become a baby. Right? So it's not easy. It is not easy
it's
at
like
all.
hitting the lottery.
It is. And
Yeah.
so that's the reason why that timeline was added to the definition, was because it takes a minute to get there. And you have to be willing to put the time and effort in to get to be able to say you truly tried.
Yeah,
Okay?
absolutely.
But is it critical to wait that timeline? No. I have patients that come to me after trying for 9 to 10 months and they're like, we're doing everything right and it's not working. And they want to do just the basic evaluation, right? And then that's where we kind of get into, well, what do you do next once you're in this boat, right?
Yeah. That's fascinating. Okay, we're already learning, you guys. What role do you think that mental health plays in fertility? Anyone who has been trying to get pregnant has had many people say to them, oh, you just need to relax. You need to be calm. It's just going to happen. What do you think about that?
Well, I usually tell them, you try and do it and then tell me how to make it happen. Because it's not easy. It is not easy at all. And yes, we do know that stress and anxiety and life occurrences, what we call environmental factors, do have a role to play. We know that if you've had a really stressful month for one reason or another, you may not ovulate that month. Right?
Oh,
so
wow.
if you have a death in the family and it really affects you, your period's going to be off and then people won't realize it because of all the grief and everything else around it. But the period cycles will take a minute to regenerate and go back to normal again. And it's because of all the hormones that come from the stress and the anxiety having that negative feedback on ovulation, because the body is not ready to be pregnant yet. It's got other stressors going on. So it's kind of shutting itself down for a minute. Going back to like caveman flight or fight in a sense, it's just not ready yet. So it's like, okay, I'm going to shut things down for a minute. Let's get through this phase and then we'll restart again. Right. And so that's the severe trauma version of things. Right. But if that was to happen in that scenario, even mild continuous stress and mild continuous anxiety and all of that stuff may have a negative role as well. Okay. And so that's the reason why I usually tell patients when they come to me is we have your back. You are now here with me. My job is to help you through this process. You need to take this off your shoulders. You need to go figure out how to, whatever it is, mindfulness, meditation, go exercise, go do what you need to do to reduce a little bit of that stress or anxiety. Know that we've got your back and we'll be helping you through this process so you don't have to burden it anymore. And then we'll get you to that end point, right? But it takes, the patients that come to me, I always say a patient that sits in front of me in my office, 90% of the time leaves with tears in their eyes, whether good tears, bad tears, some version of tears. And it usually is due to that just relief and that just lack of burden all of a sudden being on them and being able to just really experience the moment for a second. And I think once you can get past that hurdle and know that you're being cared for, I think it really kind of helps in the long run.
Talking to you right now, I can tell that you are so good at your job, because almost every woman knows at this stage of like fertility can be such a mental thing. And I think for a lot of women, like, we're thinking about it all the time. And even if like you have a great partner, it feels like you're so alone in it. To have someone like you say that, I have to imagine, like, I don't know if you have any stories that you really just saying that and being that person makes such a profound impact on so many women.
I think a lot of it, and even if it's not patients coming to me for fertility, but with PCOS or endometriosis or any one of these different, like, more chronic diseases, right? Because infertility in and of itself is a chronic disease. It is truly a disease, okay? But any of these diseases, sometimes they just don't feel heard. They don't feel supported, right? And when you can be heard and when you can be supported and you know the people that you're working with have your back and are explaining things to you, I think it just provides a next level of just comfort that you know you're in the right place, right? And I think that is, in my opinion, I've always told my patients, my appointments always go long. It's just the way it is.
No, I believe it. Because
They
you get
always
girls
go
like
long.
me who just keep talking.
Yeah, I just chit chat all the time.
Yeah.
But it has to do, in my opinion, it has to do a lot with education. Everything I'm talking to you right now about, I will teach my patients, because if they understand it and they can then own it, it makes them so much more responsible in the management of their care down the road. If they understand why we're doing what we're doing, they're more likely to want to contribute and want to participate and want to do things right, so that they can then follow the weird intricacies that come through all this. I'm pretty sure we'll get to all of the different treatment options, and they are crazy intense treatments, right?
Yeah.
But if you're up for it and you want to be part of it and you take ownership of it, then it goes right versus wrong.
Even just talking to you now, there's so many little facts that I think most women know that I stated, and hearing the why and the factfulness behind that has been, I think it's already a game changer, you guys. Talking more about the mindset of a woman and how long it takes and how mental that can be. Do you ever, and it's okay if you don't, I'm just curious, do you ever recommend for women to meditate, or are there any practices that you recommend that you think can help with that?
Oh, 100%. So, like we say, we don't know exactly how stress and anxiety and all these different things impact infertility, but we know that using these different roles will help. We have good evidence to show that using these different methods will help reduce anxiety and stress. And so if anxiety and stress can be reduced, maybe that will then help with fertility, right? So things that I recommend to my patients, depending on what they prefer, right? Because you have to go into it with an open mind. There's a little bit of a placebo effect with some of these things, okay?
That's what I hear.
Yes, there is. So you have to go into it with open mind. If you're going to be pessimistic about it, don't do it, okay? But I usually recommend at least mindfulness, because at least mindfulness helps you center yourself, right? So if you can't do meditation properly, or if you feel like you can't get on board with the proper zoning out meditation, at least mindfulness and listening to mindfulness like recordings will kind of help at least center you, okay? And it gives you coping mechanisms. I'm all about having coping mechanisms, okay? So that's my at least first thing that I usually recommend. Then comes, if you can do meditation, please go have at it. That's fantastic, right? We know we have lots of literature to help support that. And then I always recommend massage therapy.
Twist my arm.
I know, right?
Sounds
Why
great.
not? And if it means that you can't go out and get a massage, guess what? You've got a partner.
Yes.
A partner.
Hey, looking at you, Connor. Yes, we do.
Right? Yeah. So, but like those type of things can really help. Just like finding time, me time, us time, especially in the fertility world. This applies to the guy too, right? Or it applies to the partner if we have a same-sex relationship, right? they are going through it just as much as you are. They just may not show it, right? Because you're going through the physical manifestations of it, but they have the mental manifestation of it.
Yeah.
Because they are with you side by side. They want it just as much as you do, or if not more, because you also want it and they want it.
Yeah.
Right? And so they want to be there for you. It's just very hard to find out how. So finding date nights and time for yourselves that don't involve the fertility world, I think is really important as well. So massage therapy. And then we do have good evidence that acupuncture works for relieving stress and anxiety and muscle tension.
So I've heard. That sounds very stressful to me to have needles.
See, but that's the thing is if you're not going to be able to if you mentally will not be able to relax because there's needles coming at you, that's a totally different story. Then that might not be for you, right?
Yeah.
But these are all things that we have out there that we know sometimes can help. And so I will offer them all to my patients and say, hey, these are all things that are on the table to add to what we're doing, right? We talk about lifestyle modifications like weight loss and exercise and dietary routines and stuff
Drinking.
like that. Yeah. And helping modify what you're putting into your body, right? We don't have great evidence to say what you should and shouldn't do. But at the same time, if you can live a nice, healthy lifestyle, shed a few pounds if you're a little overweight, these are all things that I say are additive. It doesn't mean that you do not pursue medical management. It doesn't mean that you don't pursue an evaluation, but you do it in conjunction with that. So then that way, then you're more likely to be successful quickly. So you don't have to be there for too long.
Are there foods that you would recommend for boosting fertility? I hear about a lot of whole foods, good fats, avocado, sweet potato, eggs.
So I'd have to say there's always going to be some social media trend of some sort coming through. There was pineapple cores for a little bit, pomegranates, now French fries after transfers. That's a really big thing. Every single one of my patients goes to McDonald's after transfers to get a French fry. I don't know where it came from, but it's a thing now, apparently.
Maybe it helps them relax, so maybe that's good no matter what.
Yeah. Look, I'm never going to pass up an opportunity to go for French fries. So I tell them if they want it, go right ahead.
Go for it.
But, so there's always going to be these trends, right? But what we do know is that anything that's antioxidants, right? Those are always going to be helpful for the environment of the ovary and the environment of the testicle. Okay. So you want to have, I usually say, nice, clean, healthy living. Now, we don't exactly know what that is, but a good option is what we usually recommend is a Mediterranean diet. It's easy.
Oh, yeah.
Most people like it. It's a lot of fresh fruits, a lot of fresh vegetables. They're more complex carbs, mostly baked lean meats, right? These are things that don't have very many additives to them. They're fresh cooked, right? And it's not super heavy on dairy other than the yogurts that are in there, right? And you can manipulate that accordingly. So I'd say that's usually what we recommend. And it's got a flavor profile that most people enjoy. So that's what we usually recommend.
Okay. All good notes for us.
Yes.
All right. We are hearing more and more about PCOS affecting a woman's ability to conceive.
Yes.
In the most toddler terms possible, because I'm the toddler. Talk to us about what PCOS is and how you might recognize it.
Yes. Okay. So polycystic ovarian syndrome, or PCOS. Okay. It is a disease state that is an abnormal function of hormones. And so it's the hormones going awry. Okay. Now, this location of where those hormones are coming from affect what kind of hormone imbalance you're going to see. Okay. So typically it starts with the ovary, right? And the ovary is supposed to make estrogen, progesterone, and testosterone. When you have an abundance of estrogen and testosterone, it breaks the communication between the brain and the ovary. So then you don't get that normal feedback from the brain to the ovary saying, hey, make an egg, go do your thing. The brain's like, oh, there's already an egg being made. I don't need to do anything, right? And so then you get no egg. No egg means no ovulation, which means no pregnancy. And no ovulation means no periods, which then results in abnormal periods.
I see.
So that is the basis of PCOS, right? Now, the other hormones that are also associated with PCOS, we know PCOS is associated with a higher risk factor of heart disease, diabetes, cholesterol issues. Those are all metabolic problems that seem to be tied to PCOS, right? And so if you have an elevation in insulin, which is prediabetes, right? And then eventually diabetes if you don't take care of it, right? an elevation of insulin also does the exact same thing. It breaks that communication between the brain and the ovary, therefore then preventing an egg ovulation, then preventing pregnancy, right? So PCOS is multifactorial. It's got lots of things going on. Okay, so then if all of those things then associate with the symptoms. So what are the symptoms of PCOS, right? They are signs and symptoms of elevated testosterone in your body. So you're looking at thicker hair growth, usually midline, so upper lip, chin, chest, abdomen, right? And so that's what we call hirsutism, okay? Bad acne, so hormonally based acne, so cystic acne on the face, on the body. And then loss of hair. So we usually call it male pattern baldness, but like losing hair because of elevated testosterone levels, okay? So that's one of those, that's some of the symptoms. We talked about the menstrual irregularities. Those are big, right? That means because of all these hormones going out of whack, you basically are going to have irregular periods due to a lack of ovulation, okay? And then the third criteria that we use to diagnose PCOS is, what do the ovaries look like on the ultrasound? Are they chock full of eggs, so many eggs that that's where the hormones are coming from, okay? Or do they look normal or not? And they just look like healthy, normal ovaries. And so we have diagnostic criteria based off of the way an ultrasound shows an ovary to then add to the mix and the criteria that's necessary to diagnose a true PCOS.
If someone does have PCOS or they suspect they do, I'm guessing that you want to address that as soon as possible, right? How does that affect your fertility and really just your hormone health for the rest of your life? How soon you address that?
Yeah. So it's, a lot of the things that we see are people with very irregular bleeding. That's usually the first manifestation when people start coming for help, right? Is a lack of periods. You're missing periods. They're all over the place. And then when you are missing periods because the body's not signaling the uterus to do its monthly shed, then the uterus goes rogue and it decides to do whatever it wants to do. So you may bleed for 2 days and then it may be 3 months before you bleed again. But then now you're going to bleed for a whole month at a time and it's super heavy and extremely uncomfortable and it's not manageable. And then you become anemic and who knows, all these really bad things from that, right? And then it goes back and it disappears again for 6 months. You're like, this is so irregular, right?
Yeah.
And so when the hormones are off like that and the periods are off like that, that also can be very dangerous, right? Because you could be bleeding persistently and then become anemic. Or if you don't bleed for 6 months to a year, all that tissue is retained and then it can become precancerous, then eventually down the road cancerous.
Wow.
So you need to shed that lining. It's necessary for women to shed that lining pretty regularly so it doesn't build up and then become dangerous.
Yeah. So I'm going to guess that you want to address that as soon as possible.
As soon as possible,
Okay.
yes. And, that's where then age kind of comes into play too, because within the first year or two of the start of your period, when you're like 11, 12, periods are meant to be irregular because, again, the body has to figure it out. It hasn't reached its normal yet.
I swear I never had health class. I don't know. All of this is news to me.
Teach this in health class.
Yeah, and I think that you should be taught this. Like as a woman, and I think about, hopefully having daughters in the future, I would want to know these things, right?
It takes a minute.
Okay,
So,
yeah.
So the body has to normalize itself and it needs to get trained in what the hormones are supposed to be doing. So if they're a little irregular for the first year or two, it's okay. But if it then continues and persists and it doesn't get any better, then that's a problem.
Yeah.
Okay. Or if you're now 12, you're like 18, 19, you gain a little bit of weight because now you're out of high school, you're in college, and now your periods are going out of whack, then yes, that's a hormone imbalance. Maybe you want to get that fixed sooner rather than later.
This is why I love social media and podcasts, because I feel like we really are talking about women's health and educating all of us on this so much sooner.
Yeah.
Hopefully you guys are learning this before 31, like me, just learning this about my period. All right, that leads me to our next topic. I want to talk about infertility management.
Yes.
When it comes time for science to step in, how do you guide your patients through options like IUI, IVF, and egg freezing? What are these options and how do you address them?
Yes. And so, we alluded a little bit to the evaluation that we need to do, right? And a lot of the treatments that we recommend are based on what the evaluation shows us, okay? So we normally have to assess 3 basic things. We have to assess the sperm, How many are there? What do they look like? And are they moving or not? Because if they're not moving, they can't get to where they have to go, right? So that's important.
Yes. Mm-hmm.
So that's kind of the evaluation on the guy's side of things. It's a simple semen analysis, which is an ejaculated sample.
Mm-hmm.
Okay, so that's usually the way that goes.
It's always easier for the men.
Always
but
easier. Though I'd have to
Of
say
course,
they're more
yeah.
squeamish about it than some of my female patients. So
Well,
it's okay.
they're probably, used to PAPs and things like that. So,
exactly right,
yeah,
that
but
way.
go ahead. Yeah.
So that's the first part of the evaluation. The second part of the evaluation, like we addressed, is the hormones, right?
Mm-hmm.
We need to look at the female hormones. We have to figure out are they doing what they're supposed to be doing? And are there any hormones in the way? Thyroid, prolactin, insulin levels, those type of things that might be contributing to this not working so well, right? We also address the egg reserve level, so your anti-Müllerian hormone level, right? This is like how many eggs you have in the basket. It is a statistical number, right? Because it doesn't mean my AMH is 3, I have 3 eggs. What it means is we use that number and then we correlate it with what the general population in your age should be. And then we can say, okay, you're about average. You're 40th, 50th percentile, great, right? But if you're in the 10th percentile, that's a little low. If you're in the 30 or the 70, 80th percentile, well, you've got a lot more eggs than other 31-year-olds out there, right? And that helps us gauge also kind of what that trajectory and that potential looks like. I always like to put that caveat in when I'm talking to my patients that your egg reserve level, your AMH level, is not tied to your ability to get pregnant. So just because you have a low egg reserve level doesn't mean you can't get pregnant. And just because you have a high one doesn't mean that you have a million years to wait. Okay? It just is just a function of just how many are there currently.
Okay.
Okay? So that's the hormone side of things. And then we do an evaluation on the structures. Okay, so we have to make sure that the uterus is capable of carrying pregnancy. There isn't anything inside the uterus that could be problematic, like polyps, fibroids, blockages, scarring, who knows, based on the history. And we also want to make sure the tubes are open. So I had mentioned the fallopian tube is the highway between the egg and the sperm. So if they're blocked, then there's no way for the egg and sperm to meet, even though we have great sperm and great eggs. If they can't meet, there's no way to get pregnant, right?
Can you unblock that?
Depends on the reason why they're blocked, and it also depends on the underlying risk factors associated with unblocking them. So, if they're blocked because you surgically block them, like getting your tubes tied, if you unblock them, then, they should still function as long as there's no scarring. But if they've had an exposure to like chlamydia, gonorrhea, prior surgeries, endometriosis, they may be intrinsically scarred on the inside. And you can do a surgery to open them up, but you're not actually improving the function of the fallopian tube. It's still going to be scarred. You now just roto-rooted a hole through the adhesions. And so there may be a path, but the function still isn't perfect. Okay? And so all of this information is then correlated. I always say they're all pieces to the puzzle. And we put the puzzle together and we say, okay, where are our problems? Do we have problems? Do we not have problems? Right? And if we do have problems, great, we're going to fix them. Right? And that's where then the different treatment options come into play. If you're not ovulating regularly, let's get you some medicine to help you ovulate more regularly and see if that works. If the sperm has a little bit of a mild deficit and it's not working well, okay, let's try and put some sperm inside the uterus to flood the system with sperm and see if that works. And that's your inseminations or your IUIs.
I was going to say that's IUI.
That's your IUI, exactly. And if, for example, there's a severe deficit in sperm, or those tubes are blocked, or there's a low egg reserve level, or there's a genetic thing that we want to be assessing for, then that's where IVF comes into play, okay? And that's where then we're bypassing the fallopian tubes. We're gathering all those eggs, getting the sperm and egg forcibly together, and then fixing the embryo so that we can then put it back in, right? So there's lots of different techniques that we have, but the way we proceed with those techniques is dependent on what's going on. Okay, so I like to think of it as a stepwise approach. We start with the simple and then we get more complicated as we go. We have really great evidence to show that as you're going through the steps of what we call timed intercourse with ovulation, which is just fixing the ovulation but still having sex at home, right? That's step 1, right? And then you've got step 2, which is the inseminations or the IUIs, okay? And then step 3 is IVF. We have pretty great evidence that says if you do 3 to 4 months of that and you're still unsuccessful, you've kind of tapped out of that step. Because it should have worked by then. And if it hasn't worked, you really need to move on to something different. And so that's kind of how people progress through the steps. Even if we don't know what's wrong, if you start simple and it's not working, you try the more aggressive thing. If that's not working, you move on, right? Now, there's other studies out there that show that if you were to skip some steps along the way, it's okay. That comes to finances, it comes to other like age, and there's other things that we put into that puzzle then to decide how fast we want to progress through those steps or if we want to skip steps along the way.
Yeah. The financial barrier is such a big thing.
It is.
I have friends who have done IUI as well as IVF. It seems that IUI, which makes sense because from the little bit that I know, it is a lot less invasive and time consuming.
It is.
IUI is a fraction of the price of IVF, correct?
It is. It is.
Okay.
So if you think about all that needs to go into the process, with the IUI, we have to grow the egg, which you're doing yourself, right? We may use some ultrasound and blood work to monitor that it's happening properly. We usually will take over the ovulation in that step because we want to then know exactly when to put sperm inside the uterus. So we'll usually use what we call a trigger shot to force the ovulation on our timeline. So that way we know when to put the sperm inside the uterus.
Wow.
But
okay.
the only medical thing that you have to pay for is getting the sperm, washing it, cleaning it, concentrating it, and then putting it inside the uterus, right? So the cost of an IUI is really mostly concentrated around that final step.
Washing and cleaning the sperm.
Washing and cleaning the sperm.
All right, we're getting really off script with this, but I have to know really quick. How do you wash and clean sperm?
Oh, it's like a 2-hour thing.
Yeah.
It's a process. But the whole point of it is semen is a mix of lots of things. It's not just sperm. It's got sugars. It's got prostaglandins. It's got lots of extra mucus and all this other stuff that comes in it. The purpose of the cervix is to clean all of that out so only sperm gets inside the uterus. So if we were to just take the semen and just put it inside the uterus, you'd be so uncomfortable because all that stuff is not supposed to belong there.
Wow.
So the point of washing the sperm is cleaning out all that extra and concentrating the sperm into a media that's very friendly to the uterus. So when we put it up inside the uterus already, then it's not going to harm the uterus or hurt you in the process.
That's fascinating.
Yes.
Okay, I do want to talk a bit about egg freezing as well. I've been seeing so much more of this, and I think it ties in, at the beginning of this conversation, we were chatting about how a lot of women are choosing to pursue pregnancy later in life. Are you seeing more women looking into freezing their eggs, and what do you think is the right age to start thinking about that?
Yes. And so I would say, we talked about all the different reasons why fertility is being delayed, right? And I think the big picture here is I am starting to see a lot more patients come to me to talk about it. But it's because we're finally being more vocal about it, okay? And, I would say on the coasts, East Coast, West Coast, in law firms and in medical school and stuff like that, you have mentors that have been through it, learned from their experiences, and are telling women in the younger junior associate roles, hey, you may want to think about doing this, right? So it's been a thing, like in Hollywood. It's been a thing in New York City for a very long time. But the rest of the country hasn't caught up yet, right? They're starting to learn about it now because of social media, because they're seeing other people do it, right? And so I think now it's starting to be more popular because people are actually hearing about it, thinking about it, talking about it. But is it critical? I absolutely believe it is, okay? Like we talked about, fertility is hard, right? But fertility declines. The older we get, the more likely we are to run out of eggs. Right? Unfortunately, the woman is only born with as many eggs as they're ever going to get. Men constantly regenerate sperm, but women don't. Okay? So actually, the biggest yield of eggs that you have is when you're 20 weeks in utero. So by the time you're born, you've already lost a substantial chunk of your eggs.
Perfect.
Yeah, I know, right? So you're already born with a little bit of a handicap, right?
Yeah.
And so, but because of that, as we get older, our egg reserve declines. And as the egg reserve declines, the ability to get pregnant declines, right? And that shift seems to start happening around 35.
Okay.
So before 35, fertility rates, after around 25 or so where it kind of peaks, fertility rates start to decline about 1% to 4% per year. It's not bad, right? But after 35, they start declining somewhere around 12 to 15% per year, right? So the chance of getting pregnant, like we talked about, is around 20, 25% per month. At the age of 40, it's about 5% per month.
Wow.
Naturally, spontaneously, without any intervention, right? So it's substantial. And because of that decline, freezing your eggs, if you're not ready to have a family yet, or if you're in a relationship but you don't know how long it's going to take for you to have your second or third child, freezing eggs provides you the opportunity to have kind of an investment in your future, okay? It's not an insurance policy because there's no guaranteed payout, okay? But it is an investment into then helping you achieve your overall family goal, okay? And so the perfect age, you asked me, right?
Yes.
Is, if you look at the math, they've done a little, they've done like models of this. I would say is perfect age is around 33 to 35, okay? You're usually financially more stable to be able to pay for it because we talked about a little bit of the cost. And when you talk about the cost of IVF and egg freezing, you're looking at investing somewhere around at least 10 grand through this process.
Freezing your eggs?
Freezing your eggs.
So freezing your eggs costs about 10 grand?
About 10 grand.
Okay.
Depending on where you get it done. It may be a little cheaper in some places, maybe more expensive in others, but on average, right? And so you have to be able to spend that money. So you need to be old enough to be able to do that or have created enough of nest egg to be able to do that. But you also don't want to be too late where then your fertility rates start to decline and then the quality of those eggs may also start to decline.
Yeah.
So the perfect timeline is, I believe, is somewhere in your like mid to early 30s.
And what is the time investment? I mean, freezing your eggs, I saw some videos on social media. A girl was chronicling her journey doing it and she was saying that it wasn't that difficult. I don't know how true that is. How long does it take? What's the process like?
Yeah, so the process is usually starting with the appointment and meeting someone, figuring out if this is the right thing for you to do. And then if you are able to do it, the actual egg retrieval process takes about 2 weeks to grow the eggs to the point that we can then take them out. Okay, so it's an investment of 2 pretty intense weeks, but then you're done.
Oh,
yeah.
2 weeks.
2 weeks.
Wow. Okay, that's so quick.
Yeah. The actual appointments, like where you're coming in, taking your shots, taking your injections, and then the procedure to remove the eggs is about an intense 2 weeks, 14 to 16 days.
Okay. Wow. All right. 2 weeks. I'm like, we can do that. I don't know about the 10,000, but we can do the 2 weeks.
Yeah, the 2 weeks. Yeah. So, like I said, it is an intense 2 weeks, but that is the same as growing eggs for IVF in the fertility world. It's 2 weeks to grow eggs and take them out. Everything else takes time, right? Because then once we actually have the eggs and you have to create the embryo, then you have to put the embryo back in. And so that takes a minute, right? But the actual egg creation and removal process is pretty quick.
This ties in perfectly to my next question. I have a feeling I know what you're going to say. What would you tell women who are really worried about the fertility clock?
So I would say I think the big picture here is there's no harm in getting an assessment. There's no harm in doing the evaluation because I see patients that come to me and want that evaluation and we do it and then that next month they're pregnant. And hey, great, but then at least we got some information. We know that everything's okay. So when you want to have your next kid down the road, at least you've already done it.
Yes.
And you know that that's not going to be as of a critical problem, right? We assessed for the basics. Right?
That's how I feel too. I started a podcast, so it might be obvious. I really feel like information is power.
Yeah.
So I've always wondered, why do people encourage you to wait? Like, what would be the downside of just getting that information?
There is no downside to getting the information. The problem is that we are bound by, like, our medical pathways are kind of bound by what we were taught. Right? And so if you never experience it yourself, and if you're taught that this is the definition and the guideline, then it doesn't really trigger in their brain if it's outside of that. Does that make sense? I don't know if that makes sense.
No, it makes sense.
It's in regards to the medical recommendation to go and get the testing, right?
Yeah.
I think in the world of being the person that experiences it, it's a long wait. To be like,
yes, even just month to month.
And month to month, this is getting really annoying and super frustrating. And why do I have to keep doing the same thing? Feel like I'm knocking my head against a wall, right? And so I think in that scenario, yes, I think getting information and asking your GYN to do that and like at least basic testing, blood work, a semen analysis, those aren't hard.
Yeah.
Right? The reason the rest of the testing isn't really recommended is because it is the test to look at the uterus and the tubes. That's more of an invasive procedure, right? So why put yourself at risk for infection and other things? Very, very, very rare, but it's not just a blood draw. So because of that, then usually the next step isn't usually recommended until you kind of hit more of that definition.
I just think as we continue to progress as a society and look at healthcare differently, I don't understand why it's not recommended for men and women to get those tests and just understand that about their body by their 20s. If I was in healthcare, I don't know, if I had a daughter in their 20s, which, very far down the line for me, most likely, but I would think that, hey, what's the harm 20 years old just to find that out about your body? You could address endometriosis earlier. You could address PCOS earlier. And also, what's the harm in knowing by the time you're 20 what that journey may look like for you? I don't get why we don't look into those things earlier.
I think it's because we don't have really great especially when it comes to hormones, we don't have really great established data for what that looks like in kids and in younger adults because nobody's ever tested for it.
Oh, okay.
So it's hard for us to know what an average AMH is for a 15-year-old. And it's been done and it's all over the map. Like we have no idea. And we don't have progressive data to say, okay, at 15 they were this, at 20 they were this, at 25 they were this, and this was their trajectory, right? And so because we don't have that information, it's very hard as a provider for us to be like, let's get it. And then when you get it, then you don't really know what it means.
Yeah.
Do you see what I'm saying? And so I think that's the reason why people have been so hesitant to even recommend it. We have society recommendations that say routine egg reserve testing is not recommended because it doesn't really have a true impact on overall outcome. Yes, you'll be able to identify that small subset of patients where it's low, like pretty low to begin with, and you're like, oh shoot, we need to do something now.
Yeah.
Right? But that's maybe 10% of the population.
But wouldn't it be worth it?
Okay,
Devil's advocate.
Coming from the fertility side of things, like you said, knowledge is power. For me, information is power. If I could have a trajectory map of what your egg reserve level looked like for like the last 10, 15 years, I will take it. Right?
You can tell me if I'm wrong. And just in my head, I'm like, that seems like it's worth it.
I will take it. So in my line of work, yes, we do like that information and we thrive on that information. I think it's just the question is for the general population, where is its utility, right? And that's the problem. But I do agree with you. I think it would be nice to be able to have that roadmap for sure, 100%.
Just things to think about. I would love to know, what is one story of hope from a patient that has stayed with you throughout your career?
Oh man. And this patient, though I'm not going to use her name, she's done some articles with me and stuff like that. So she has publicized her story. But they were the sweetest couple. And so they were in the military. And because of being in the military, they had delayed their fertility. And, their relationship started a little later in life and stuff like that as well. And they traveled to come and see me. And they had tried the simple, trying to get pregnant. It didn't work. They tried a few IUIs. It didn't work. And they were in the world of IVF. But her egg reserve level was so low, right? So low. And the first thing she said to me is, I wish somebody would have told me that I would have had these problems now. And I think she was 38 when we first started taking care of her. Okay. And she was like, I wish I would have known. I wish I would have known. I wish I could have done something. Right. But, egg freezing didn't become non-experimental until 2012. So, it's new. It's a new thing. We didn't have it beforehand, or we did, but we used it in experimental basis, like in cancer patients, right? So that was an option for her at 38 already. Okay. So we did the IVF, and unfortunately we didn't get enough eggs. And then the next time around we did it again, and she got maybe one embryo, but it was abnormal, right? And so then we got to this point where we're like, oh, I think we need to do an egg donor. And she just was not up for it. And then she walked away for a minute and was like, we're not going to do an egg donor. So then we talked about embryo donation. And that seemed to click for them because they were like, you know what, instead of creating new embryos, let's use embryos that have been created before and give them life because they weren't going to be used otherwise, right? And so we took them through this embryo donation journey, and they got pregnant, and they've now had 2 kids through it, and they are the biggest advocates for understanding third-party reproduction, which is using somebody else's eggs or sperm or embryos to help you create the family that you want, even though you may not be able to do it yourself.
Well, that is beautiful.
Yes.
Oh, all right. If there is a woman listening right now who is struggling with their fertility and they feel very alone in the process and they're just not sure what to do next, what would be your message to them?
I would say my message, if you're struggling out there, is find someone who can be an advocate for you. If you feel like you've gone through so much, you can't advocate for yourself anymore, go to a provider that would be able to do that for you. And that would be any reproductive endocrinologist, any fertility doctor, whether you want to do IVF or you just want more information. That is our job. Our job is to help you gather that information and put those puzzle pieces together so that we can then explain to you what might be happening, what might not be happening, and what your best avenue is. And then if you take that information and you walk away, that's okay. Like, no one's going to force you or be resentful that you came to see us. It's not a waste of our time. But we want to be able to provide you with that hope and that understanding of what's going on. And if we do see a problem, we can explain to you how it would be fixed and how easy or maybe more difficult it might be to get you to the end point of building your family. But building a family is our end goal, and we will get you there one way or another.
That's some fantastic advice. Okay, Dr. Thakore, the name of this podcast is Water Your Garden. You know, the precipice is that every episode is a chance to pour into yourself, i.e. water your own garden. I would love to know, what does that look like for you? What are things that you do in your personal life to pour into yourself?
I would have to say, I think now more recently is doing stuff like this, being a patient advocate and getting out there and speaking about it, because these are all pent up feelings. And when you see them day in and day out with your patients, but you have no avenue to be able to express how important it is, to be able to do these type of things mentally for me are fantastic. And then it's just on the family side of things is just getting to spend time with my kids and just watching them grow, and the turmoil and craziness of teaching a young human how to be a human is a new adventure, a daily new adventure that we have to deal with, but is also fascinating.
Because you have a 4 and 6-year-old.
I do. I have a 4 and a 6-year-old.
Oh, that's such an exciting time. I love those ages.
They're fantastic.
Yeah.
And, you know, my daughter is ridiculously independent and has a mind of her own at 6, which is hard. And then I have this beautiful baby boy who I absolutely love, but is a little bit more timid and meek, and you're just trying to get him to like grow out of his shell. And so it's an interesting combo between the two of them, but it's fabulous.
Oh, well, I can tell you're the best mom. So I'm sure they just have the best role models.
Thank you. I appreciate it.
Oh, of course. Dr. Thakore, we appreciate you coming on so much. I know myself and everyone listening has learned so much from you. If we do want to learn more from you, can we follow you on social media, or what are ways that we can keep in touch with you?
So I would say the best way to get in touch with us if you want any medical opinions is to come reach out to one of our offices. So I work for IVF Michigan and Ohio Fertility Centers. We're a Pinnacle Fertility organization. Okay, I'm based out in Grand Rapids, and I see people up in Traverse City too. So I've got basically the west side of the state. I have a social media handle as well. It's
You don't know it? No, you know, I'm going to put it in the beginning of this episode. Okay. But we love that you're so grounded you don't know your social media handles. I'll say it at the beginning of the episode.
Thank you.
You guys, I'll say it at the beginning. Find it in the caption. Okay. And it's Instagram, right?
Yes.
Okay, so Instagram.
Yes.
Perfect.
So, I know that's so bad. I should really
No,
know
we're going to tag you in this episode. So hit the link in the bio, you guys. You can find it there.
Yeah, exactly. It has something to do with my Thakore IVF doctor. I don't know. It's something like that.
Okay. We'll find out.
In true transparency, my fellow helped me create it, so I don't really remember what it is.
I love that. Fantastic fellow. Okay. Mm-hmm. Well, Dr. Thakore, thank you so much. Hopefully we can have you on again, because I feel like we just, haven't even covered all the things that you could help us learn.
We literally scratched the tip of the iceberg here. We've got so much more to talk about.
To be continued.
Yes.